Yes, thank you. Thank you, Professor Martin, and thank you for having me to speak today. It's a pleasure to be here. I'd like to speak today on a topic that I think gives a lot of general and indeed pediatric ophthalmologists that they find difficult at times, and hopefully this talk will give you some tools to help you with your decision making. So when I'm teaching our trainees about pediatric ophthalmology, I try to get them to frame their management plan based on around these 4 key principles that you see on the slide. So the first is to identify and treat any life or eye-threatening pathology. The second is to put a clear image on the retina, and that usually means correcting refractive error. Equalise the vision in each eye, and that's your amblyopia treatment, and optimise ocular alignment where possible. So essentially, there's no point addressing the point below if you haven't addressed the one above. And this talk is really all about addressing the first point here. And of course, in pediatric ophthalmology, I find myself constantly worried that I'm missing a brain tumour in children. But in fact, it's really quite rare to have strabismus as the only presenting sign of a brain tumour. And when I was trying to write this talk and looking for cases to include, I asked around our orthoptic staff who have been working at the Children's Hospital at Westmead in Sydney for 20 years, and they really struggled to think of a case where strabismus was the only presenting feature initially. So that's somewhat reassuring. Now, I think it was Professor Martin who told me once that during my training that the difference between paediatric and adult ophthalmology is that in adults, it's easy to elicit the signs, but it's harder to know what to do. Whereas in paediatrics, it's much harder to elicit the signs, but once you do, it's easy to know what to do. And I think this is really the point that I want to get across in this talk, that if you can elicit all the typical signs of a childhood strabismus syndrome, and of course you have to know what they are, and confidently rule out all the red flags, then you can safely not investigate any further. So the first question to ask yourself is, does this fit a typical childhood strabismus syndrome? Does it have the typical features, and is it following the typical natural history? Do you have typical examination findings? Is this a well child with no red flags? And are they responding to treatment in the way that you would expect? Now, what do I mean by no red flags? Regression of developmental milestones and neurological symptoms such as headache, weakness, seizures, behavioural change and clumsiness. Now, these are all important questions to specifically ask parents, because often if they have noticed something subtle, they won't necessarily tell you about it because they may not realise that that's even related to their eye problem, to their child's eye problem. Ophthalmic red flags to look out for in strabismus are unexplained poor vision, and this is a really important one. As I think was mentioned in the very first talk by Dr. Agarwal, making sure that children are tested with an age-appropriate vision test is extremely important, and that follows as you follow the patient along. So they might start out when they first come to see you with preferential looking tests, but as they grow and age and become more mature, they should be upgraded to a more mature visual acuity test. And so it's important that that is being followed up, because often if it's not and a child is actually regressing or has neurological symptoms, they may not be graduating to the next test, the next age-appropriate test. And so you may think that their vision is stable, but actually there's unexplained poor vision there. So just an important point to keep in the back of your mind. RAPD, or relative afferent pupillary defect, ptosis, variability of the squint, unexplained nystagmus, double vision, disc swelling and retinal changes are some of the key ophthalmic red flags to look out for. So what do I not investigate? These are the classic, I think, group of childhood strabismus syndromes that you really should have a good idea of what they look like and what the classic features are. So if I have a patient that fits into one of these categories neatly, and they're a well child, and there are no red flags, and they're responding to treatment in the way I'd expect, then I don't investigate them. So just to give you a quick example, a baby presents to you at 11 months of age with a large, constant esotropia who appears to cross-fixate and has equal vision. They're a well baby, they're growing and developing as you'd expect, and they've got all the features of infantile esotropia, and you'd want to diagnose them as infantile esotropia. However, mum tells you that the turn only developed at 9 months of age. And she pulls out her phone, and you go back through the 40,000 photos on her phone of the child, and you really can't prove that the turn was there before 6 months of age. Now, that doesn't fit the definition of infantile esotropia, and I really think you're obliged to further investigate this child with an MRI of their brain. So what do I always investigate? As I've already said, any atypical features or red flags. Any strabismus that fits a typical neurological pattern. So things like dorsal midbrain syndrome or internuclear ophthalmoplegia. It's important to know the features of these because there's a high incidence of intracranial pathology with these strabismus patterns. Any sudden onset acquired cranial nerve palsy in a child, and this includes a post-spiral 6 nerve palsy, and I may have colleagues out there that disagree with me on this, but I would investigate these cases. A constant exotropia in children under 2. Of course, you have to rule out, make sure that they have normal vision and a normal ocular exam to rule out a sensory cause of an exotropia. But I don't necessarily scan these patients straight away, but I will refer them to a pediatrician for a neurodevelopmental assessment, because there's a high association in exotropia in this age group with systemic syndromes such as cerebral palsy, and there may be subtle signs there that the paediatrician will pick up that haven't been picked up previously. Any variable signs, especially with fluctuating ptosis, I'll investigate for myasthenia gravis, as I think was mentioned in the previous talk. Any traumatic or restrictive strabismus, I think, should be further investigated. Acquired Brown syndrome should be investigated, and this should include inflammatory bloods. And the last one, I think, is the most tricky one, the acquired non-accommodative esotropia. This is the one that I think we all find difficult sometimes to know whether to investigate or not. And look, some of the signs to look out for, which might make you more inclined to scan a patient, are no prior period of intermittency or of an intermittent esotropia, no history of interruption to fusion. Now that might be, an example of that would be patching. An onset in a child 5 years or more, double vision, distance angle greater than near, an A pattern esotropia, lack of fusion on a synoptophore. Now that's tricky to get in a young child, but it might be useful in an older child. And the absence of significant uncorrected refractive error. And that can be hypermetropia or myopia. So these are some of the things to look out for when you're trying to make a decision. So this case, I think, highlights some of these points. This was a 5-year-old girl who was out in the backyard playing Let's Go Cross-Eyed with her friend. And immediately thereafter, she came into the kitchen and mum noticed a small convergent strabismus, which was constant and stayed that way for a week. After a while, it started to get more noticeable and the angle started to get larger. And so mum presented with her child to an ophthalmologist. She had no prior period of intermittency, and there were lots of old photos to confirm this. So this squint was definitely not there in any way, shape or form before this acute episode. And she was an otherwise very fit and healthy young girl with no neurological signs or symptoms and certainly no double vision. Her visual acuity for distance and near was normal for her age. She had a 35 prism diopter left esotropia, which was comitant and equal for distance and near. Her ductions were full. Her pupils were normal. Her anterior and posterior segment examination was also normal, and she definitely didn't have disc swelling. A cycloplegic retinoscopy was performed, and she had plus 1.5 diopters of hypermetropia in both eyes, which is really not significant, but for what it was worth, we trialled a pair of glasses to see if it made any difference to the strabismus. However, concurrently, we also ordered an MRI of her brain and orbits with contrast. So I think the key feature here, even though there's no disc swelling, even though this is a well child with no neurological features, were that there was no prior period of intermittency of the squint, and there was a lack of significant refractive error. So this is her MRI, and as you can see, she has a large posterior fossa cerebellar tumour with some obstructive hydrocephalus, and it turned out to be a pilocytic astrocytoma. So this young girl underwent successful complete excision and post-operatively her eyes are straight and she has 6/6 vision in both eyes and normal stereo acuity. So it's a very good outcome, really. So what scan do I order? Now, obviously you have to weigh up the pros and cons of CT versus MRI, and I'm sure most of you out there are familiar with these pros and cons. CT obviously is fast and accessible. There's less claustrophobia. It's less affected by a motion artifact, but unfortunately there are high doses of ionizing radiation. MRI, on the other hand, is very slow. It often requires a general anaesthetic in a young child, which means it can be incredibly difficult to access. And certainly we find this in Sydney. It's very difficult to access MRI under general anaesthesia. But there is no ionizing radiation and there's certainly better soft tissue detail. So where possible, I always order an MRI, but I appreciate that accessibility is different in different parts of the world, and really you have to sort of make the best decision that you can based on what resources you have available. So my top tips for when to scan strabismus are old photographs and videos. We live in an age where every parent has an iPhone or some sort of device, and thousands of videos and photographs. They're extremely helpful to prove the timing of onset of these strabismus syndromes, and also to prove that there is a strabismus sometimes when you can't see it in your office, when it's an intermittent strabismus. Foster a good relationship with your local friendly paediatrician, because sometimes when you're just not sure whether to get a scan or not, it can be really helpful to get a bit of systemic information or a systemic assessment on the child to help you make your decision. Normal optic nerves do not exclude a brain tumour, and I think the case that I described made that point quite clearly. And follow up on your patient. Make sure they're responding to treatment. If you haven't decided to further investigate, make sure they respond to treatment in the way you expect, and look for evolving signs. You can always change your mind on whether to scan, and just make sure that you ask a specific question on MRI on your MRI or CT request form, because that really helps the radiologist. And don't be shy to talk to the radiologist if it's reported as normal but you're still concerned. So look, I hope that's been helpful, and again, it's been a real pleasure to talk here today. Thank you.